Hi, my name is Atif Darwish, professor and consultant of obstetrics and gynecology. In this short lecture, I'd like to highlight the importance of routine administration or prescription of folic acid supplementation during pregnancy. Actually, it is a simple drug, easy drug, cheap drug, available elsewhere, and unfortunately, its importance is not well studied and not well addressed in the clinical practice. That's why I plan through this lecture that doctors should be aware about the significance of this important supplement. You know that folic acid is a synthetic folate, actually comes from pharmacies or from pharmaceutical companies. Its absorption is not too high, 85% is absorbed. But if folate comes from diet, it's dietary folate, and this is natural folate, and is less absorbed, 50% of it is absorbed. And both forms are inactive forms of vitamin B9, which is the folic acid. Which is a crucial coenzyme. Actually, it is an essential nutrient, which means that it is not formed by the body. It should come from outside. You told me that the oral administration, whether synthetic or diet, is inactive. So from where can the body get the folic acid vitamin B9? It should be activated in the body. Activation is methylation, which is methyl folate, which is active form of folic acid. But natural folic acid comes from diet. Folate actually is a Latin word, means green leaves. So don't forget that it comes from green leafy vegetables. These are the main source of vitamin B9, including also whole grain products, beans, peanuts, and some animal sources like liver, seafood, and eggs. So now we come to the active form, the synthetic folic acid, the natural folate are inactive. So active should be methyl folate. And this active form is 7 times more bioavailable than folic acid or folate, highly absorbable. No need for enzymatic conversion in the liver. More effective, immediately available, does not accumulate in blood in cases of decreased hepatic transformation. So the active form is the important form of folic acid, which is methyl folate. This is the methyl folate, and this is folic acid. So methyl folate means that it bypasses the change of synthetic folic acid, which is transformed to dietary folic acid or folate, which is dihydro, 2 hydrogen atoms, dihydrofolate, and with an important enzyme, which is dihydrofolate reductase, it's formed or transformed into tetrahydro, 4 hydrogens, and this tetrahydro is transformed to methylene tetrahydrofolate, adding methylene group CH2, and then with an important enzyme, which is called methylene tetrahydrofolate reductase enzyme, it's transformed to methyl tetrahydrofolate, which is the active form of folic acid. So there is a circle of changes, which is called folate cycle. And this folate cycle has an important value of changing the inactive forms, diet or synthetic, to active form, which is methyl folate. But we have to know that there are some anomalies or some problems in the methylene tetrahydrofolate reductase enzyme that may be seen in some individuals. And this polymorphism is common within the human genome, and in some cases can result in production of proteins with altered biologic activities. This means that methylfolate is good and important, but dependent on an enzyme, which is reductase enzyme. And this enzyme in some people has some problems. Those people have mutation in this enzyme, so they cannot produce methylfolate. And I told you it is the active form. So in those individuals, if you give them folic acid synthetic folate dietary, they will not get benefit because no enzyme that changes it into the active form. And those people are liable to have some problems of deficiency of methylfolate because it will lead to increased homocysteine level in blood, and it leads to vasculopathy and inadequate fetal-maternal circulation. So in those cases with methylene tetrahydrofolate reductase mutation, or polymorphism, they are liable to have these diseases. And those cases, particularly those with history of recurrent pregnant loss, should receive methylfolate rather than folic acid or folate. Okay, you told me that methylfolate is the active form. I'll give all pregnant ladies methylfolate to save time, to avoid the circle in the liver, to avoid these enzymatic steps. Is it right or wrong? Actually, if you don't give methylfolate, you are right. Why? Because the majority of pregnant people are able to convert folic acid to folate or methylfolate without any problem. So the deficiency, which means that the deficiency of the reductase enzyme is rare, it's not common. So why to give all people methylfolate and they have this enzyme in their body? This is the first point. Number two, the CDC emphasizes that there is no scientific evidence that methylfolate prevents congenital anomalies, particularly neural tube defects. This is because most of the studies are done or were done based on folic acid supplements, folic acid, synthetic folic acid, but they were not done on methylfolate. We don't know that methylfolate can prevent congenital anomalies, particularly neural tube defects. And here comes an ethical concern that if the folic acid is the standard with all publications or research that it helps prevent neural tube defects, assessing whether alternative supplements, which is methylfolate, is advisable would involve asking a group of people. You have to tell the patient that if I give you methylfolate, this is not known to prevent congenital anomalies, not known to take a non-vital supplement, and possibly there is a risk of fetal abnormalities. Up to you if you need methylfolate. This is your responsibility because studies are based on synthetic folic acid, not on folate. So these are the arguments that we have to give folic acid, not to give methylfolate. And also some publications found that early data suggests supplementation with L-methylfolate rather than folic acid may mitigate or ameliorate or increase risks of high-dose folate supplementation. This is the group of pros of not giving methylfolate, but against this group that we have a category of people with polymorphism or mutations. They may get benefit of giving them methylfolate, and those people are not actually, unfortunately, are not detected in the population because routine testing for methylene tetrahydrofolate reductase polymorphism is not recommended. So methylfolate instead of folic acid can be administered or given or prescribed to women with a history of neural tube defects or preterm birth. And other studies found that it should or recommended to be given to people with history of recurrent pregnancy loss and positive reductase gene mutation. So there are two teams, but generally speaking, all over the world, the supplementation is dependent on folic acid. So in conclusion of this part of the lecture, routine folic acid is recommended, but routine L-methylfolate is not recommended. The second point of this lecture, what's the value of giving methylfolate or folic acid that will be activated to methylfolate? Methylfolate, which means methyl group CH3, which means movement of one carbon unit comes from amino acids like serine, glycine, and others. This methyl group goes to target molecule for cellular processes, which is called methylation, which means transmission of methyl group to these target molecules. Why to take methyl group? Because they are important for gene formation or enhancement, protein synthesis, DNA, RNA, amino acids, and phospholipid synthesis. So methylation is crucial in the cell division and regulation of gene expression through epigenesis and imprinting. It regulates gametogenesis and continued embryo development. Brain development and maturation also is dependent on methylation, on correct lipid methylation. In addition, continued neuronal function dependent on biologic amine that require methylation. So methylation is crucial for the important vital functions or processes of the body, including DNA synthesis, praying, gametogenesis, embryos, and so on. So the methyl group is crucial, and don't forget that methylation is essential. What happens if there is no methylation? If there is no methylation, it's called demethylation, and this can occur if there is deficiency of one of the important nutrients essential for methylation, particularly essential amino acid, methionine, folate, B9, B6, B12, riboflavin, choline, and others. In deficiency of one or more of these essential nutrients, there will be epigenetic disorders even before conception, abnormal gene activity or inactivity, birth defects during pregnancy, slowed brain growth, congenital development, anemia, cancer, diabetes, atherosclerosis, thrombosis, or other diseases. So methylation is important. And here comes the role of folate or vitamin B9. How to transfer methyl group to the target organ to help DNA synthesis, lipid, proteins, and others. This can be done through folate cycle, already mentioned, methionine cycle, and choline cycle. To simplify this topic, which is one carbon cycle, I have to stress that we have some beneficial substances which are essential amino acid, which is methionine, and glutathione, which is actually combination of three non-essential amino acids, which are glycine, cysteine, and glutamic acid. Also, we have harmful substances. These harmful substances are homocysteine and S-adenosine homocysteine. The beneficial substances help methylation, which is essential for cell division, and they are actually antioxidants. The harmful substances are oxidative stress substances, and they are toxic to the human. So our target is to decrease harmful substances, homocysteine and S-adenosine homocysteine, and to increase synthesis of beneficial substances, methionine and glutathione. And you have to know that methionine is a precursor of glutathione. So don't forget that homocysteine is a key determinant of methylation cycle. And in normal individual, there should be very little homocysteine. In our bodies, we should have very little amount of homocysteine. Why? Because homocysteine is toxic, is harmful, is not good. It leads to toxicity on accumulation of the body. So everybody of us should have very little amount of homocysteine. So the target of methylation is to get rid of the methyl of the homocysteine, which is toxic, and adenosyl homocysteine, because they lead to vasculopathy, cardiovascular diseases, congenital anomalies, and others, anemia and others. So in the normal individual, homocysteine should be converted to another beneficial substance, which is called homocysteine reduction. This is the best solution to get rid of homocysteine from the body. If there is deficiency of the essential amino acids, it seems logic that homocysteine should be changed or transformed to essential amino acids. The essential amino acid of concern in this methylation cycle is methionine. So homocysteine, if there is deficiency of methionine, it should be transformed to methionine. And methionine is crucial in synthesis of SAM, which is S-adenosyl methionine, which gives the methyl group responsible for methylation. And this pathway is dependent on folate, vitamin B12, and methyl tetrahydrofolate reductase enzyme. But if there is sufficient methionine in the body, homocysteine is harmful. It should be changed to another non-group, which is non-essential amino acid, and it should be transformed to cysteine, or helping transform of serine to glycine, or formation of glutathione from, which is combination of three essential, non-essential amino acids, cysteine, glycine, and glutamic acid. Also, it helps transform of choline to betamine, which is again a non-essential amino acid. So the main target is that homocysteine is harmful. If there is deficiency of methionine, it should be transformed to methionine. If there is sufficient methionine, it will be transformed to non-essential amino acids. Here is the cycle of recycling of homocysteine to form essential amino acid, which is methionine. And this is a remethylation of homocysteine to form methionine that is transformed to SAM, giving methyl group for target molecule methylation, and the metabolite is SA, which is S-adenosyl homocysteine that is metabolized to homocysteine and remethylated and so on. And this is a cycle recycling of homocysteine to form methionine. But the step of remethylation of homocysteine to methionine is dependent on two enzymes and two vitamins. The two enzymes are methionine synthase enzyme plus vitamin B12 combination, and also folate, which is B9, and methylene tetrahydrofolate reductase enzyme. So don't forget, two vitamin B and two enzymes are responsible for methylation of the homocysteine to be changed to essential amino acid, which is methionine, and then methylation of the body, of the DNA and others. This circle is or cycle is essential when there is deficiency of methionine. But if there is sufficient methionine in the body, homocysteine should be removed from circulation by transforming it to cysteine, and this is the main non-essential amino acid fate of homocysteine in support of what's called CBS, which is cystathionine beta synthase enzyme, one enzyme plus vitamin B6. By this way, this harmful homocysteine is transformed to beneficial cysteine, which is non-essential amino acid. Also, homocysteine is supporting the transfer of serine to glycine. What's the value? Glycine plus cysteine and glutamate or glutamic acid will form an important maestro antioxidant of the body, which is glutathione. So all these cycles are stimulated by changing homocysteine to these by stimulation of the homocysteine. Again, homocysteine is stimulating transform of choline to betamine, which is a non-essential amino acid that will ultimately lead to methionine, which is essential amino acid. So these steps can occur if there is sufficient methionine. So it goes to the non-essential amino acid pathway, betamine, cysteine, glycine, and glutathione. This, this part dependent on CBS and vitamin B6. So we have two pathways of homocysteine. Okay, what's the problem? If this pathway is not working, the other pathway will work. What's the problem in pregnancy and in oocyte maturation? The pregnancy is that non-essential amino acid pathway is not expressed in the oocyte and early embryo. Don't forget this important sentence, that the pathway of non-essential amino acids is not expressed in the oocyte and early embryo. So the early embryo and oocyte are dependent on the essential amino acid pathway. So this is the only available pathway, which is methionine pathway, which is dependent on two enzymes and two vitamin B, as I told you. So in pregnancy, this pathway, CBS and betamine and betaine pathway are not expressed in the oocyte and embryo, early embryo, also poorly expressed in the placenta. Moreover, in pregnancy, there is a high need to glutathione, which is the maestro antioxidant or the master antioxidant coming from these three non-essential amino acids under the effect of transformation of homocysteine. Also, betaine synthesis is not expressed. So there is no expression of betaine and CBS, and there is increased need of glutathione. So in pregnancy, the uterus or the fetus is only dependent on the essential amino acid pathway, which is methionine, and also in the oocyte. Methionine is important. And this is dependent on two enzymes, vitamin B9 and 12, and two enzymes, methionine and methylene tetrahydrofolate reductase. And here comes this important of folic acid supplementation. If we don't give the patient folate, pregnant lady, and she has folate deficiency, there is a risk of decreased methylation and demethylation with genetic and congenital anomalies. So by this way, we understood that administration of folic acid supplementation is to enhance the only pathway of fate of homocysteine in the body during pregnancy and also for ovarian maturation. This is the pathway of folic acid changed to dihydrofolate under the effect of dihydrofolate reductase enzyme and formed to tetrahydro and then methylene tetrahydro, and then under the effect of methylene tetrahydrofolate reductase formed to methyl tetrahydrofolate with methyl group that with aid of vitamin B12 and the carbon atom or methyl group comes from serine transformed to glycine, and this will stimulate methionine cycle. And this is folate cycle, and this is methionine cycle. Important to have SAM, which is methyl group supplement, and the metabolite is AH, which will be transformed to homocysteine. Both of them are toxic. So the neural tube development of the human being is dependent on the master antioxidant cysteine, glycine, glutamic acid, which form glutathione. And all these steps are dependent on are important. And in the oocytes and early embryo, CBS and betaine pathways are not expressed. That's why, in addition to a high requirement of large amount of glutathione, so here comes the critical role of administration of folic acid. So the functions of folate or folic acid is it is an essential vitamin B that plays a role in DNA synthesis and cell division to support growth and fetal development. And during pregnancy, there is an increased demand for folate due to the rapid fetal growth. So the main function of folic acid in the early pregnancy is to help neural tube development. And from the previous slides, we know that this will be achieved by increased glutathione, increased methionine, essential amino acid, and decreased homocysteine. But if the patient has folate deficiency, there is increased homocysteine, which is harmful and toxic, decreased methionine, which is essential amino acids, decreased glutathione, which is combination of 3 non-essential amino acids. In such a case, neural tube defects can develop. Also, if folic acid is essential for DNA and RNA synthesis by methylation, metabolization of amino acids necessary for cell development, helpful for erythrobiosis by inducing maturation or helping maturation of RBCs and preventing folate deficiency, and sometimes can help prevent or minimize side effects of methotrexate. If we talk about methotrexate, you know that it is an antineoplastic agent, but later is considered as immunomodulator and anti-inflammatory and commonly given as a treatment of autoimmune diseases nowadays. Methotrexate binds and irreversibly inhibits dihydrofolate reductase enzyme. By this way, there will not be folate, there will not be tetrahydro, not be methyl folate, no DNA synthesis, and no inflammatory cells. This is the main mechanism of methotrexate. But the methotrexate is helpful in achieving these achievements. No DNA synthesis of malignant cells or inflammation in autoimmune diseases, but at the same time, methotrexate affects other cells of the body. So if we give supplementation with folic acid or better by folinic acid, this will inhibit the harmful or side effects of the methotrexate on the body, like ulceration of the mouth and other side effects of this methotrexate as an anti-neoplastic or anti-inflammatory drug. And here comes the role of folate in treatment by the antifolate, which is methotrexate. We give supplement to minimize the side effects, which is called rescue therapy. And this is because the administration of folinic acid, which is leucovorin, commonly known as leucovorin, by stimulation of changing stimulation of formyl tetrahydrofolate, which is transformed to tetrahydrofolate and then methylene tetrahydrofolate and methyl tetrahydrofolate. This pathway avoids the pathway of dihydrofolate reductase, which is affected by methotrexate. So it goes through another pathway, aiming at minimizing side effects of the methotrexate to help the other healthy tissues of the body. We have to know that there is what's called folic acid deficiency. Of course, neural tube defects are one of the manifestations. Folic acid deficiency anemia is another manifestation. Some depression, general weakness, red tongue or sores of the tongue, and manifestations of hyperhomocystinemia, which may lead to vascular and cardiac diseases and even stroke. In addition to some pale skin and sometimes diarrhea, these are the main folic acid deficiency manifestations. And if we have CBC of a patient with folic acid deficiency, you will see there is megaloblastic anemia, and this means that the size of the RBCs increases more than 100 femtoliter per cell, and this is due to folate deficiency and, of course, folate and vitamin B12 together. If there is poor dietary intake, this will lead to nuclear maturation, arrest, or defect. So there will be discrepancy between the development of cytoplasm, which is dependent on RNA, which is little affected by the decreased folate, and the size of the nucleus, which is mainly due to impaired DNA synthesis, which is highly affected by folate. So the size of the cell will be megaloblastic cells, and this discrepancy should be put in mind. And this should be differentiated from another type of megaloblastic anemia, which is pernicious anemia due to poor absorption of vitamin B12 from the GIT. What about the ovaries? I told you that folic acid, which is vitamin B9, is essential for DNA functions and to some extent RNA to formation of nucleotide biosynthesis. So it's helpful for as an antioxidant, also for organogenesis, improving oogenesis, improving blood flow, and prevention of IUGR, neural tube defects, early miscarriage, and preterm labor, as mentioned in publications. In male, also, it's helpful for the DNA synthesis and repair, RNA synthesis and cell growth. Also, it is an antioxidant, so it's helpful for spermatogenesis and decrease testicular apoptotic gene expression. If it is combined with zinc, this will lead to a good antioxidant effect, scavenging ROS from the male as found in many studies. So we have we know now that the folic acid or folate is essential for DNA methylation and essential for growth and for formation of the human being in early pregnancy and the oocyte and sperms at the same time. How to increase the folate level? This can come from three ways: by increased consumption of food fortified with folic acid like bread, cereals, rice, pasta, and others. And this is actually done in around 80 countries all over the world, fortifying the food with folic acid to prevent the side effects, including anemia and others. The second way is to increase consumption of food rich in folate. I told you green vegetables, orange juice, some meat and others, fish and eggs and others. The third is to give supplements. And this supplementation is actually or ideally starts 3 months prior to conception, not with the onset of pregnancy. It's a common mistake by ladies. When they do pregnancy test positive, they start folic acid. No, she is waiting for pregnancy or expecting pregnancy. Anytime she has to start it at least 3 months before conception and continue first 3 months or first 12 weeks of pregnancy. This is the ideal protocol or ideal prescription of this supplement. But we have to differentiate between two groups of ladies, low risk and high risk women. Low risk with no history of neural tube defects, no family history of neural tube defects, no anemia and no folic acid deficiency anemia or folate deficiency anemia, non-use of anticonvulsant drugs. Those are low risk. They can use 400 microgram daily as recommended by the WHO starting 3 months before pregnancy, and throughout pregnancy and even during lactation in the postpartum period. But in high-risk group, they have to receive not 400 microgram, they have to receive 4 milligram to 5 milligram daily and receive information about the risks of recurrence. So we have to know also that folic acid is not only for the first trimester or first 12 weeks, it should be continued till the end of pregnancy as recommended by many studies or meta-analyses that it may lead to prevent preterm birth, and high folate level and folic acid supplementation are significant associated with low overall risk of overall preterm birth, and high maternal folate in late pregnancy are associated with low preterm birth. So it's recommended, particularly in patients with history of preterm birth, to have a continuation of the therapy or supplement till the end of pregnancy. Also, it has a neuroprotective effect during pregnancy if it is used for a long time. We have to know that there are some drugs that may interact with folic acid, like anti-malaria drugs like barbiturates, and some anticonvulsants like phenytoin. But some studies found even in patients with anticonvulsants, they have to use the folic acid supplement to decrease the risk of preterm birth. And in conclusion of this talk, I would like to say that folic acid is a cheap but valuable supplement. Understanding the role of folic acid in methylation of DNA is vital to convince women to keep on its use. Continuation of folic acid supplementation beyond 12 weeks is advisable, and more research is required to explore the role of folic acid in prevention of preeclampsia and other obstetric problems. Thank you.